DTHF Research Meetings, your deep dive into the latest in research.
Thank you everyone for joining today for today's research meeting. I'll just give a brief intro to our speaker today. Today we have Lynn Bust presenting for us. She's a project manager of the LGBTQI Health Division at the Desmond Tutu Health Foundation and possesses a Master of Public Health degree with a specialization in health policy and systems research. She's a passionate advocate for the LGBTQI+ community and is deeply involved in expanding the LGBT+ Health Division's research scope on health issues, aiming for equitable access to healthcare for LGBTQI+ people. With a background in both academia and the nonprofit sector, Lynn brings extensive experience in research and project management. And today she'll be talking to us about evidence-informed care for transgender and gender diverse people in South Africa. And I'll hand over to Lynn. I have asked everyone in the chat that they keep themselves muted. And then at the end, I'm sure Lynn will be happy to answer some questions or receive some feedback that you have. And for that, you can just unmute yourself at that point. Or you can type a question in the chat. I'll be monitoring that as well. And we are recording the session just so that you are aware of that as well. Okay, Lynn, over to you.
Thanks, Nadine, and hi everyone. Really happy to be here. So as Nadine said, my name is Lynn. My pronouns are she, her, hers, and I am the research project manager for the LGBT+ Health Division at Desmond Tutu Health Foundation. The title of my talk today is Evidence-Informed Care for Transgender and Gender Diverse People in South Africa, Gender Identity, Desire and Access to Social, Legal and Medical Transition and HIV Services for Transgender and Gender Diverse People. So given the global and national context, there is urgent need for local evidence to understand healthcare access for trans and gender diverse people in South Africa. So the LGBT+ Health Division in 2024 conducted a study, and today I will be presenting some of the important findings from that study. The LGBT+ Health Division is a health research division based at J52 at Groote Schuur Hospital, and we're involved in a number of different research projects, including clinical trials, primarily HIV prevention trials looking at men who have sex with men and transgender men and women, but we also have several qualitative research projects and health systems research projects going at the moment too. Let me just see if I can get to my next slide. I don't know why. There we go. Cool. So some background to the study. So trans and gender diverse people are a marginalized community who face discrimination and stigma both globally and in South Africa. Trans and gender diverse people are defined as those whose gender identity differs from their sex assigned at birth and includes both transgender women or gender diverse and non-binary people assigned male at birth and transgender men or gender diverse and non-binary people assigned female at birth. And intersex people also fit into both of these categories, but typically they're assigned either male or female at birth. So research globally and in South Africa has shown a high prevalence of adverse health outcomes for this population, including high rates of HIV, STIs, mental health disorders, violence, and substance abuse. And these health outcomes are often made worse by discrimination and lack of access to care in health systems. Some trans and gender diverse people suffer from gender dysphoria, which is defined as a sense of unease that a person may have because of a mismatch between their sex assigned at birth and their gender identity, and this can contribute to mental distress and poor mental health outcomes. So one way to alleviate gender dysphoria is through gender-affirming care, and this encompasses a range of social, psychological, behavioral, and medical interventions designed to support and affirm an individual's gender identity when it conflicts with the gender they were assigned at birth. So gender-affirming care includes several different aspects or modalities, such as social transition, which means changing your names or pronouns or your gender expression or appearance to align with your gender identity. Legal transition, which means legally changing your name or your gender marker in your ID documents. In South Africa, you are legally able to do this, although it is a bit of a process. Non-medical gender affirming practices. So for people assigned female at birth, this means binding breasts or packing. And for people assigned male at birth, this includes tucking your penis and padding breasts. There's also psychosocial care, and this is any support for mental well-being relating to one's transition, and medical transition, which includes hormone therapy and gender affirming surgery. So trans and gender diverse people's need to access gender affirming care and the factors that influence this process have not been sufficiently explored in South Africa. And in addition, with regards to HIV in the trans and gender diverse population, transgender women have an HIV prevalence of over 50% in South Africa, which is very high compared to a prevalence rate of 14% in the general population. There's also a lack of data regarding HIV prevalence for transgender men and other gender diverse populations. So there's an identified need to integrate investigation of gender affirming care with need and access for HIV testing, prevention, and treatment services for trans and gender diverse people. So this study aimed to close this gap in knowledge with the following aim and objectives. The overall aim of the study was to describe access to gender affirming care and HIV services for transgender and gender diverse populations in both the Western and the Eastern Cape, South Africa. The objectives were to describe the self-identified gender identities of gender nonconforming people, to describe for transgender and gender diverse individuals their need and access to social transition, legal transition, non-medical gender affirming practices, psychosocial care, hormone therapy, and surgery. Third, to describe for transgender and gender diverse individuals their need and access to HIV prevention, testing, and treatment services. And lastly, to identify the barriers and facilitators to accessing gender affirming care and HIV services for these populations. So this study was an exploratory mixed method study. Our study population was a total of 150 trans and gender diverse people in both the Western Cape and the Eastern Cape. We utilized convenient sampling through a number of different methods, including through our Safe Space network, social media, word of mouth, sharing with our partners and community-based organizations, as well as through LGBTQI+ community members in both provinces. The study consists of two phases. So phase 1 is a quantitative structured survey of access to gender affirming care and HIV services for trans and gender diverse people. And this phase has been completed, and I will be presenting the findings from this phase today. Phase 2 will be qualitative focus groups to further understand gender identities of trans and gender diverse individuals and how this relates to their desire to transition and access gender affirming care, as well as the factors that influence access to gender affirming care and HIV services. And this has not yet been completed, but aims to build on phase 1, and we're hoping to have those findings and share them with you all next year sometime. The study has UCT ethics approval. So for phase 1 of our study, our data collection and analysis, we conducted quantitative surveys one-on-one in person with trained LGBTQI+ health researchers at J52 at our offices at Groote Schuur Hospital, as well as the DTHF research site in East London. We obtained informed consent prior to participation in the study, and all efforts were taken to respect participants' privacy and confidentiality. Data were initially recorded on paper surveys, which were then translated to REDCap immediately after the interview by the interviewer, and then a second researcher quality checked the data entry on REDCap. Once all surveys and quality checks were completed, all data were downloaded and descriptive analyses were completed on Stata 18. All data in the analysis and write-up and presented today are de-identified. So to present some key findings from the study, in terms of demographics, we had a total of 150 trans and gender diverse respondents to the survey. 111 of these respondents were people assigned male at birth, and 39, so just over a quarter, were people assigned female at birth. And you can see here that we had quite a diverse group in terms of race and age group. In terms of residents, you can see that 30% came from the Cape Town CBD, the City Bowl. just around a quarter, 25% were in PAL, and then we had 20 respondents, so 13%, which were in East London in the Eastern Cape. And these kind of pockets of residency were mostly due to our recruitment network. So other demographics, in terms of relationship status, the majority of our respondents were single. 42% were single and not dating, and 31% were single and dating. For living arrangements, a very low percent, only 3% were living with their partners, but 19%, so that's almost 20%, were homeless. So either living in a shelter, moving around, and on the streets. In terms of their education, also quite a diverse range, but you can see the majority had at least completed high school. And in terms of unemployment, there were 66%, which is quite substantial, of our respondents were unemployed. In terms of gender identity and sexual attraction, so we asked our respondents how they identified. You can see that 6 of our respondents, so 4%, identified as male, 4% female, 11% in total identified as trans males or trans men, and you can see that 44% of those were people assigned female at birth. Similarly, 47% of our total respondents identified as trans female and trans women, and 63% were people assigned male at birth. We also had quite a substantial proportion of respondents, so 34% in total, identify as gender diverse, and this was an umbrella term that included people that identified as non-binary, gender queer, gender fluid, agender, or gender non-conforming. With regards to sexual attraction, there was also quite a diverse range of sexual attraction across people assigned male and female at birth. You can see the majority of our participants were attracted to men, 68%, but 19% were attracted to people of all sexes and genders as well. And that differed across both people assigned male and female at birth. So gender identity and appearance, 10 of our respondents, so 7%, were intersex, and the median age that respondents realized that they were trans or non-binary was 14, which is quite old, but anecdotally, the kind of evidence that came out of that was around the fact that this was often when people had the language to explain their identities as well. In terms of the gender lived in day to day, 14% of our respondents lived day to day as men or boys, 49% lived as women or girls, and just over a quarter, 26%, were living or had gender appearance as non-binary, genderqueer, and agender day to day. The majority, so 61%, were very comfortable with the word transgender being used to describe them, and 65% were satisfied or very satisfied with their appearance. However, despite being satisfied with their appearance, there was still an expressed need for gender-affirming care. And the next sections, I will now present different modalities of gender-affirming care and the access and need to these different modalities as we go. So this is for social transition. So you can see out of 150 respondents in total, 129, so 86% of respondents had explained to friends and to family their gender identity. 56% of respondents in total had changed their first name, 89% had changed their pronouns, and 89% had changed their appearance as well. So overall, out of all of our respondents, 148 out of 150, so 99% of respondents had done one of the 4 of the listed above to socially transition. In terms of legal transition, out of the 150 respondents, only 6, so 4% of our respondents had legally changed their gender marker or their name. And 11 respondents, so 7%, were in progress, so currently changing either their gender marker or their name on their ID document. And of those who had not legally transitioned, so that was a remaining 133 respondents, we then asked respondents if they had not, would they like to, and 95 of those respondents, so 71% had said, yes, I would like to legally change my gender marker or my name. So this column on the right here shows desire or need to access care. Psychosocial care, so this is any support for psychosocial care relating to a trans or gender diverse person's transition. So out of the 150 respondents, 67 respondents, so 45% had received psychosocial care relating to their transition. And out of the remaining 83 respondents, 77% wished to access psychosocial care to assist in their transition process. In terms of non-medical gender-affirming practice, so these tables are divided based on assigned sex at birth, recognizing that these practices will differ based on the sex assigned at birth. So for assigned female at birth, we had 39 respondents. 51% of those were binding their breasts, and 36% of those were packing. And of those who were not, 47% wanted to bind their breasts and 20% wanted to pack. Similarly, for people assigned male at birth, 56% were padding their breasts and 87%, so the vast majority, were tucking their penis. And for those who wanted to, we identified that 37% wanted to pad their breasts and 21% wanted to tuck their penis who had not. There were fairly similar statistics for voice training as well. So 21% of people assigned female at birth and 37% of people assigned male at birth had voice training, and 26% of assigned female at birth and 44% of assigned male at birth wanted to have voice training. So moving on to hormones. So for our assigned female at birth respondents, 44% were accessing or had access to testosterone. And of those who had not, 50% wished to access testosterone. For those assigned male at birth, 22% were currently accessing or had access estrogen. And of those that had not, 67% wanted to. There were similar statistics for testosterone blockers, so 18% of AMAB respondents had access to testosterone blockers, but 58% of those who had not wanted to access them. For surgery, and these findings are rather interesting as well, out of all of our respondents for both AFAB and AMAB, only 3 of our AFAB respondents had had surgery. So 7 or 8% of our AFAB respondents had surgery. None of our AFAB respondents had had bottom surgery, and none of our AMAB respondents had had either top or bottom surgery. So in terms of desire or need for surgery, for those who had not accessed surgery, 64% of AFAB respondents wanted top surgery, and just over or just about a third of respondents for AFAB wanted bottom surgery. For AMAB respondents, 56% wanted top surgery and 50% wanted bottom surgery. So in terms of satisfaction with gender-affirming care, we asked respondents who had accessed or gone through that gender-affirming care modality, their satisfaction with that process or with accessing that care. So the totals are reflected here, the total number of respondents who had accessed that modality. So you can see the vast majority for all modalities of gender-affirming care were respondents were overwhelmingly satisfied or very satisfied, and that ranged from 87% being satisfied with social transition to 67% being satisfied or very satisfied with hormones. Some respondents were kind of neutral around these things, but you can see very small percentages being dissatisfied or very dissatisfied with accessing these services. So it's very low, 6% for hormones and non-medical gender affirming practices. The highest is 13% for psychosocial care. So my last result section is around HIV testing, prevention and treatment. So overall, 99% of respondents had had an HIV test, 64% of respondents had had a test in the last 6 months. And of the 149 respondents who had had HIV tests, 104 respondents, so 70%, were HIV negative, and 27.5% were HIV positive. And you can see the results somewhat differ between the AMAB respondents and AFAB respondents, particularly for those who were HIV positive. So for AMAB, we had 34% of respondents were people living with HIV, and for the AFAB respondents, only 8% were people living with HIV. So in terms of prevention and treatment, so for all those who were HIV negative, 22% of these respondents were currently taking PrEP. 25, so a quarter, had taken PrEP in the past, but it stopped. And 53% had never used PrEP. For those who would like to use PrEP, 71% of, so this refers also, the total is out of those who were not currently taking PrEP, for who would like to use it. 71% of AMAB respondents wanted to use PrEP, and 27% of AFAB respondents wanted to use PrEP, with a total of 53% of all respondents wanting to use PrEP who were not currently. And for HIV treatment, so we had 41 respondents who were living with HIV. Of those, 78% in total were currently taking antiretroviral treatment. That was 100% of our AFAB respondents who were living with HIV, and 76% of our AMAB respondents. 21% of our AMAB respondents had also previously taken ART, and of those not currently taking ART, 77% or 78% wish to. So, a summary of our key findings: the study recruited a diverse sample across racial groups, ages, and locations of both AMAB and AFAB respondents. The demographics showed a vulnerable population with almost 20% homeless and a very high unemployment rate. These socioeconomic factors demand further exploration in access to healthcare for trans and gender diverse people. A large proportion of both the AMAB and AFAB respondents identified as gender diverse or non-binary, which is quite interesting. The reported HIV prevalence was high in the AMAB population, with a lower but substantial HIV prevalence of 8% in the assigned female at birth group as well. Most respondents were satisfied with their appearance, but many had not accessed gender-affirming care despite wanting to do so. And the findings show a significant gap between those who had accessed care and those who wanted to or needed to. So in terms of access to gender-affirming care, the majority of respondents had socially transitioned or engaged in non-medical gender-affirming practice. The least accessed gender-affirming care were legal transition, which was 4%, and surgery, which was 3%, which are both incredibly low. Less than half of AFAB respondents had accessed testosterone, while only 22% of AMAB respondents had accessed estrogen. So you can see from these findings how incredibly limited access to gender-affirming care is, particularly legal and medical gender-affirming care. So we need to identify ways in which to provide access to legal transition and medical gender-affirming care, including psychosocial care, without pathologizing clients. So, for example, to ensure that psychosocial care is not a requirement in order to access medical gender-affirming care. But you can see from the demographics of these population that access to psychosocial care is desperately needed and can be a way to provide support for trans and gender diverse people, particularly those in vulnerable positions in society. So in terms of the need for gender-affirming care, most respondents who had not yet accessed gender-affirming care expressed a desire for legal transition, for psychosocial care, and for gender-affirming hormones. And this is fairly similar, although a bit higher, to other studies that have been conducted in South Africa, such as by van der Merwe et al., which found that 49% of transgender women in South Africa would like hormones, and 44% would like counseling, but had not yet pursued these options. The desire or the need for surgical transition was more nuanced. So the majority of AFAB respondents wanted top surgery versus 33% wanting bottom surgery. So this was substantially lower. And for AMAB respondents, the desire for top surgery and bottom surgery was similar, around 50%. And the similar results have been found in other studies, such as in the US. Puckett et al. Found that 55% of transgender women would like bottom surgery. So that's people assigned male at birth, and 25% of transgender men would like bottom surgery in future in the US. So there is a need to understand why the need or desire for gender-affirming care varies, particularly for medical gender-affirming care, as well as to understand the factors that influence this process. For example, is it happiness with your body? Is it mistrust in the health system? Is it affordability? And we're hoping that phase 2, so the qualitative focus group discussions, will provide some answers to these questions to understand this further as well. So in terms of HIV, there was good access to HIV testing. So 99% of our respondents had access to an HIV test. The HIV prevalence was similar to other national statistics for people assigned male at birth, which shows an incredibly vulnerable population to HIV, which similar statistics have shown. But surprisingly, the AFAB respondent HIV prevalence was 8%, which indicates a need for further studies to determine accurate HIV prevalence in people assigned female at birth and gender diverse people, because very little research has been done on this globally and in South Africa. In terms of HIV prevention and treatment, 22% of HIV negative respondents were taking PrEP, and 78% of people living with HIV were on antiretroviral treatment. Of those who were not on PrEP or ART, the vast majority wanted to access, and this again shows a gap between need and desire to access care and actually being able to access those services. And also what was important to note from the findings is that HIV prevention and treatment needs differed between the AMAB and the AFAB respondents, and this needs further exploration. So overall, the limitations of this study, this was a fairly small pilot sample size that was not statistically powered, which limits the generalizability of the findings. So there is need for larger national longitudinal studies on access to gender-affirming care and HIV services for trans and gender diverse people. We also recruited through convenience sampling, which resulted in differences in recruitment. So we had substantially more people assigned male at birth who responded to the survey. So we need to kind of investigate this further, investigate the differences between AMAB, AFAB, as well as intersex people, particularly given that 10 of our respondents were intersex as well, and also understand where the need and access to care differs between trans and gender diverse groups as well, particularly binary trans groups, so transgender men and women, and gender diverse and non-binary groups. There was self-reporting of data, and there's a risk that this may introduce bias, particularly, for example, around HIV status, treatment, and PrEP uptake. The survey tool that was utilized was also derived from a literature review of global surveys on access to care for trans and gender diverse people, but has not been validated in the South African context. So there is a need to develop and validate a localized tool for broader implementation. And also our sample size in the Eastern Cape was only 20, which was relatively small. So there's a need for larger studies that focus particularly on understudied and rural areas where access may differ. So from the study, we can make several recommendations. The first of which is to expand access to legal transition through establishing integrated pathways between healthcare providers and the Department of Home Affairs. And this is really important given the low number of people who had accessed legal transition and the high number of people who needed or wanted to. Second is to identify ways to provide psychosocial care without this being a barrier to entry for other gender-affirming care services. And like I said before, without pathologizing access to gender-affirming care as well. So there's a desperate need for psychosocial care and for this to be better integrated into the health system, and also to explore particular forms and mechanisms of psychosocial care, such as peer support and psychospiritual care as well. And this should be done in a way so as not to prevent or kind of ensure that access to other medical gender-affirming care practices takes longer. Another recommendation is to expand surgical capacity for gender-affirming procedures through strengthening referral networks, building knowledgeable multidisciplinary surgical teams, and advocating for inclusion of gender-affirming surgeries and health insurance coverage. Next is to explore interventions to address the socioeconomic barriers to accessing gender-affirming healthcare. And I think our findings really reinforce the vulnerability of the demographics of this population. So looking at their socioeconomic factors and how this influences their access to gender-affirming care. And lastly, to strengthen education and information accessibility about gender-affirming care, including where services are available and the potential risks and benefits of various gender-affirming care modalities. So there's really a need to provide more information around where services are available and how people can access them. So a dissemination strategy for these findings. So we will share a report with all respondents to the survey via the contact details they provided. And in addition to presentation of the findings at this meeting, where I'm hoping to get good feedback from everybody here about the findings, we will hold another in-person stakeholder engagement meeting with community-based organizations and LGBTQI+ community members, to which all respondents to the survey will also be invited. We also aim to publish in a South African academic journal. So in conclusion, there is expressed need for comprehensive support for gender-affirming care, including legal transition, psychosocial support, hormones, and surgery, along with reported difficulties in accessing care. And this highlights the necessity for multidisciplinary teams to provide and promote better access to these essential services. Findings show the variable needs of each trans and gender diverse person, and there is a deep need for individualized, multifaceted approach to gender-affirming care. There is also need to research and analyze disparities in access based on demographics and gender identity, as well as the factors that influence this and how this can inform targeted interventions. Lastly, further research is needed to develop targeted, sustainable solutions that comprehensively address healthcare for trans and gender diverse people. So that is it for me. I think we have good time for questions and engagement as well. I did just want to say a huge thank you to all the respondents who participated in the survey. We really appreciate you. This research would not be possible without you, and also a way to illuminate the challenges in accessing care in order to provide better care for other trans and gender diverse people who need to access care. A huge thank you as well to the LGBT+ Health Division team, to our team of data collectors and research fellows. Thanks to Saskia, Savuka, Olivia, Zara, and Zambini. It's really appreciated. Thanks to Dr. Richard Kaplan, head of the division, as well as Amelia Mfiki and the community engagement and outreach team. A massive thank you to our recruitment network as well, and all the individuals and organizations who assisted in recruitment for this study. There were several individuals who were really key amongst our network, so thank you for your time in assisting with this, and a special thanks to Triangle Project, Gender Dynamics, UCT Faculty of Health Sciences, and Rainbow UCT for assisting in recruitment and sharing amongst your networks. And last but definitely not least, thank you to our funders for providing support to conduct this really important research, both the NIH Fogarty International Center and NIH Office of AIDS Research. That's it from me. Here are my contact details if you wish to engage further. Otherwise, happy to take questions and have a chat with everybody now.
Great, thank you so much, Lynn. Very nice presentation and a lot of very important stats and coming out of that. I will open the floor up now for any questions. Anyone who'd like to ask or comment or provide feedback can unmute themselves and ask Lynn directly. In the meantime, Lynn, I do have a question. I was just wondering at the moment, what are the what do you see or think the potential barriers are to accessing hormone treatment? Because the number of individuals who did access was low compared to the ones who had access it. So does that involve, does it necessitate a psychosocial evaluation which might prevent people from accessing it, or is it a pathologizing that occurs? That's why one might not access. What do you think at this point? What's your guess around that?
Thanks, Nadine. Yeah, that's a great question because you could see that difference between actually people who have accessed hormones and those who wanted to. And so some of our survey findings, which I didn't present today, we did actually kind of look at barriers and facilitators, and we're hoping to pull that together once we've conducted the focus groups as well to kind of get a more comprehensive picture or story to tell there. I think the factors that influence access to care are quite varied for each trans and gender diverse person, but I think there are several kind of systemic factors which prevent access to hormones currently. And I think some of that is that there are a very limited number of places providing those services. So we have the GSH Transgender Clinic, and we have WITS RHI, which has several sites, and some other, I think, tertiary healthcare facilities may be providing it in other kind of urban settings. But besides that, it's very hard to access hormones, particularly in the public health sector. And currently you do, at least at the GSH Trans Clinic, the first step is to go through psychiatry, and you get an assessment there. And often even before you go to psych, you are even referred from, a CBO, like community-based organization, where you'll have another kind of social worker or counselor assess you first. So currently, yes, there are these barriers to having that psych assessment first, and then you have to go into a waiting list, and it'll take several months before you can even then get your appointment with endocrine to be able to get hormones. So I think, kind of what I wanted to say in terms of the findings is that there's such a need for psychosocial care for trans and gender diverse people. And we've seen that given their vulnerabilities from the demographics as well. But we need to look at ways in which we can provide that services in addition to people being able to access medical gender affirming care as well. And I did present some of these preliminary findings to the GSH Trans Clinic as well. And Prof. Adele Murray, who's head of the clinic, kind of had the same feedback as well, because really psychosocial care in our system and in our health system is not well integrated, and there's such a need to provide those services as well. So I hope that answers your question. I see there's another hand up as well.
Yes, thank you. Yes, someone has put up their hand. You can just unmute yourself and ask Lynn directly.
Hi, KL Dunkel, pronouns they, them, currently independent consulting. A couple of questions. The first was, and you partially answered it in your last answer, but very explicitly, where are people accessing care? And particularly, to what extent is it public, private, or NGO, CBO?
Mm-hmm.
Which I think probably would speak to different barriers going along those different routes. The other thing I'm interested in is whether you've thought about any benchmarking of these numbers against other settings, either in the global south or the global north, not I mean, South Africa internal dynamics and issues obviously matter for improving South African systems and are vitally important. But I'm wondering where there are benchmarks and also to the extent to which those might provide useful strategies for increasing access. That's a step beyond where you are, but I'm just curious.
Thanks. Yeah, great questions. The first question, where are people accessing care? So we did actually collect data on this, and it didn't, I mean, quite an extensive survey. It was various across both public and private. Most of, I think, kind of the majority were accessing care in the public sector. And that was either at the GSH Trans Clinic or Wits, either in Belleville here or in the sites in East London and the Eastern Cape as well. So that's where the majority, as well as, sorry, I'm just trying to remember this off the top of my head. I can also get a full breakdown to you as well if you're interested, as Health for Men and Ivan Toms as well came up quite a bit for hormones as well. But I think, I think our population size would be much bigger, and I think this speaks to your second question as well, much more interesting to get a much larger number so that we would be able to generalize this at the national level. Obviously, our statistics were very focused to the Western Cape and a small proportion in the Eastern Cape as well. But I think really what's needed is national collection of this data to understand kind of this national picture and then situate that in the global context too. And I think from some of our findings, we could compare and find quite similar findings to what is happening on the global context. But yeah, I think that is next steps, next aim for us. I mean, so many interesting things came up out of this study too. So how do we conduct a bigger study to find these things as well? And then lastly, I think is just an important thing is to advocate for kind of national collection of data collection on gender identity too, because if you can link this to a national data system that's collecting these things, it would be really useful as well.
Yeah, I think my only note on thinking about national level data collection is you're going to have we will have enormous variation by province. I'm quite, there's no way that Western Cape and Gauteng don't have totally different dynamics than, say, Limpopo.
Mm-hmm. Definitely, yeah. And I think trying to get some of that data out would be really interesting as well.
Thanks for that.
Cool. Any other questions? Is there anything on the chat? I haven't.
In the chat, there were questions around accessing your data, but Richard has replied to one of the messages. So I think, I'm not sure if you're going to make the slides available right away, because I'm assuming you want to have it published and then maybe share that, but I'll ask you to comment on that. So yeah, there was a question around if one can access the findings or the presentation at this point.
Sure, I will have to check about sharing the slides, but definitely when we either have a full report or our write-up for publication, we'll happily share that with everybody.
Okay, and another hand has gone up. Kia, you can just unmute yourself and ask your question to Lynn.
Hi, Lynn. Afternoon, everybody. Excuse my voice. I have a hoarse voice at the moment. It's this insane weather, I think, and heat wave and thunderstorms. So please forgive me if I'm not clear. Please do tell me if you can't hear what I'm saying. I'm sitting on the SOGIS committee for the DBE. My name is Kia Mulupe. I'm the mother of the youngest Black born male, now transgender female teenager. She's 19 now. my question to you is, I was able to move her from, I would then say, I guess, 10 years ago, from public care or private care rather, to public care. Then only Steve Biko around Gauteng area was offering the services, however, not for children under the age of 16. So as probably most people here would know, there is confusion around access age, whether it be legal or medical transitioning. So the hormone, the endocrinology department, Steve Biko has been doing fantastically well. But what I found in general is that there is a regression in progress, particularly within the academic hospitals, which I would think within public care, that would be strategic to target based on the accessibility to public healthcare. So I'm wondering why there is a sudden regression, almost cease to access to that, and whether or not the new government of national unity is going to have an impact on that at all, or whether you have any statistics based on research done on that. I've said quite a mouthful. I hope that makes sense.
Thanks, Kira. Welcome. Lovely to have you. So if I understood your question correctly, it's kind of why is there a regression in the services provided in the public health sector? Is that correct?
Correct.
Yeah. So I mean, do you want the short answer or the long answer? I think in short, I think we have to situate kind of care provision in the global context where we are seeing kind of an increasing rise in opposition and pushback to gender affirming care. And I think in the South African context, the issue is that there is no national policy. We have great HIV clinician South African guidelines on gender affirming care, but those are not kind of, implemented at a standardized level, have not been taken up by the National Department of Health, right? So it seems to be that in the public health sector, it really just depends on the people who are providing those services, who is at those hospitals, their capacity, the politics within those spaces, etc., the resources available, and it's kind of up to individuals within the system to then be able to provide those services. And I think that ultimately boils down to how variable the services are, and that's kind of what happens across South Africa, is that you just have these pockets of experts or specialists providing care because they're able to, but there's what we need to advocate for, and like you said, with the Government of National Unity and NHI, and at the national policy level for kind of more inclusion of gender affirming care. There needs to be recognition of the importance of it, and that we need to kind of have national guidelines and standardized ways to integrate these into our health systems as well. Yeah, I don't know if anybody has anything to add to that. We have a lot of kind of experts on this call as well that might be able to add to that too. And I see there's more stuff going on in the chat, so please tell me if I've missed anything.
And the chat is just around CPT and how to contact you. So we've shared those details.
Right. Oh, thanks. I see you've shared my email address. Yes. Very happy to chat further. Cool. Richard.
Richard has a question. Can I unmute yourself, Richard? Go ahead.
Trying to unmute.
There we go. We can hear you.
Yeah, with regards to the last question, it might be interesting to share. I'm not sure that everybody is aware of the Western Cape position statement, the Department of Health on transgender care. And maybe if you want to talk about that, Lynn, because I think that's probably interesting for other provinces.
Sure. Thanks, Richard. So yeah, really exciting that the Western Cape Department of Health and Wellness has released I think it's a draft, it's currently for comment, but it's being circulated in the Western Cape, and it's a position paper on evidence-informed care for trans and gender diverse people. And this is really fantastic. I really commend the Department of Health and Wellness for doing this. They've been in talks about this for a while, and in fact, we've had some support at our LGBTQ Health and Advocacy Symposiums. So Dr. Hilary Gooiman had come a few years previously and then kind of taken this work up and has formed advisory committees around this, which have then put together this position paper, which I think we can also share as well. That basically kind of outlines their commitment to and a plan for inclusion of transgender health at the provincial level. But yeah, really this is a first step in, like I said, kind of getting the standardized way of holding public sector accountable to include gender affirming care in their services. And, you know, other provinces could also adapt this. I think it would take some kind of, you know, organizing and advocacy around this work. And also if we can advocate for guidelines like this to be taken up at the national level, I think that would be really fantastic as well. I don't know if there's anything else you want to add, Richard.
No, that's great. That's great. Thanks.
Okay, then I think if there are no other questions and no other comments in the chat, I think we'll end over here, Lynn. Thanks again for presenting this very new and exciting data. Oh, wait, there was a hand that popped up quickly. Is it Cheryl? Did you want to ask something? Or you back out? It's a safe space. You can go ahead, ask. Have a question? No? Okay. She didn't mean to put up her hand. That's fine. Okay, so then I think we'll end it here. We have put the contact details for Lynn in the chat, and if you have questions around CPD points, you can email me. I've put my email address in the chat as well. And yes, then thanks again, Lynn, for presenting today, and I'll see hopefully many of you at our next research meeting as well.
Thanks, Nadine. Thanks everyone for listening and for your great questions. I hope to carry on the discussion via email.
Great, thank you. Bye, everyone.
Great, thanks. Bye.
Bye.
DTHF Research Meetings, your deep dive into the latest in research.